Begin, and I want to introduce the head of our department, Dr. Yemelyanov Dmitry Nikolaevich.
Good morning, guys. We start our lectures in this distant form. Be ready. Lectures will be delivered in time according to schedule. So, at the beginning of the lecture, I ask all of you to write your name and group number on the wall in Vkontakte. We'll check, and you should write your name and group number at the beginning of the lecture and at the end of the lecture. Again, not in the chat. In the chat, you can write your questions if something not clear, but you should write your name in Vkontakte on the wall, and again we'll check who is present, who is absent. Okay? Is it clear? So, we start our lecture. We continue our lecture in cardiology, and today we'll talk about rheumatic fever and mitral heart valve disease. Rheumatic fever is an inflammatory disease that occurs in children and young adults. The first attack usually occurs at between 5 and 15 years of age as a result of infection with group A streptococci, or as you learn in microbiology, beta hemolytic streptococcus group A. It affects the heart, skin, joints, and central nerve system. This disease is common in Middle and Far East, Eastern Europe, South America. It's rare in United Kingdom, Western Europe, North America, and this decline in the incidence of rheumatic fever from 10% of children in 20s to 0.01 today parallels the reduction in all streptococcal infections and is largely due to improved hygiene and use of antibiotics. So we talk that this is social disease, rheumatic fever, and with improvement of social life, social conditions, life level, number of patients with this disease decrease many times. Again, please write your presence not in the chat of the lecture, of the video. Write your names on the wall in Vkontakte. Clear? Not in the chat. In the chat, you should use chat to ask some questions. So, we'll continue. Pharyngeal infections with group A streptococcus may be followed by the clinical syndrome of rheumatic fever. So, rheumatic fever is not simple infectious disease because I will tell you later that this disease affects heart, joints, nerve system, but you will never find germs streptococcus in the heart, in the joints. The mechanism is something different. So this happened due to so-called autoimmune reaction. This is infection autoimmune disease. Autoimmune reaction triggered by molecular mimicry between M proteins of the infecting Streptococcus pyogenes and cardiac myosin and laminin. And the condition is not due to direct infection of the heart or to the production of a toxin. Okay, let me explain you once more. This is infection, but this infection, streptococcal, usually these germs usually live somewhere in pharynx. They are causing streptococcus pharyngitis, for example. Yeah? But then what happened? Immune system tried to fight actually with these germs and release antibodies, and these antibodies attack these germs, and this is normal. But for some reason, antigens of infection of streptococcal germs, similar to antigens of our own tissues, similar to antigens of M proteins, to antigens of cardiac myosin, laminin, so proteins of our own body. And what happened? When immune system attack germs at the same time, the same antibodies, the same immune cells, they attack our own cells, our own proteins, our own cells and our own proteins. As a result, we have inflammation. What is attack of immune system? This inflammation. As a result, we have inflammation of the heart, inflammation of joints, inflammation of central nervous system, without presence of germs in the heart, in joints, and in nerve system. So this is autoimmune mechanism. Infection, autoimmune mechanism. Why some people suffer, other people not, we don't know. This is genetic predisposal. This is some people genetically predisposal to this disease. Remember, please, the same mechanism, or you can't remember, the same mechanism we have, for example, for glomerulonephritis. We'll talk later when we'll talk about nephrology. And as a result of this attack, of this autoimmune affection of the heart, we have progressive valvular heart disease. Valvular heart disease, and this is the most dangerous outcome of this condition. If we talk about pathology, all three layers of the heart may be affected. All three layers of the heart may be affected. And the characteristic lesion of rheumatic carditis is Aschoff nodula, so-called, which is a granulomatous lesion with a central necrotic area occurring in the myocardium, particularly in the subendocardium of the left ventricle. Small watery vegetations may develop on the endocardium, particularly on the heart valves. This leads to some degree of valvular regurgitation. You can see this is mitral valve, and on the edge of mitral valve you can see such vegetation. This is also inflammatory process. Serofibrinosis effusion characterizes the acute pericarditis that occur. Synovial membranes acutely inflamed during rheumatic fever, and subcutaneous nodules, which are also granulomatous lesions, are seen in acute stage of the disease. If we talk about clinical features, this disease presents suddenly, with fever. I see some delay in translation in our lecture. That's why you can see actually valvular lesions. So now we talk about pathology and we talk about clinical features. So disease presents suddenly with fever, joint pains, malaise or weakness, loss of appetite. The clinical features depend on the organs that are involved. The main organs which are affected by rheumatic fever, this is heart. When people talk about rheumatic fever, people believe that this is disease of joints. It's not true. The main target for this disease is the heart. And in the past, doctors told that rheumatic fever is a disease which bites the heart and just touch joints. That bite the heart. It means that the most dangerous, this is damage of the heart. Joints, yes, affected, but this is not a big problem actually. So again, rheumatic fever, that's why it usually starts with fever. Then joints, pain, weakness, malaise, loss of appetite, and clinical features depend on the organs that are involved. Diagnosis relies on the presence of two or more major clinical manifestations, or one major manifestation plus two or more minor features. And this is known as Duquette-Jones criteria. So, according to Duquette-Jones criteria, we have major criteria. Which are carditis, so inflammation of the heart, polyarthritis, This is inflammation of joints. Chorea, this is actually damage of the central nerve system. Damage of the central nerve system. Then erythema marginatum. Erythema marginatum. This is damage of the skin. Damage of the skin. And subcutaneous nodulus. Subcutaneous nodulus. This is also damage of the skin. Again, major criteria. Major criteria: carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodulus. Minor criteria, small criteria. This or additional criteria. This is fever. This is arthralgia. Difference between arthritis and arthralgia. Arthralgia, this is just a pain. This is just a pain. Arthritis, when together with the pain, we have what? Tumor, choler, dolor, functia lesa. When we have swelling of joints, when we have actually redness of joints. So this is arthritis. Arthralgia, this is just a pain. Arthralgia, this is just a pain. Previous rheumatic fever. So if you know that this patient suffered from rheumatic fever in the past and he presents some signs, no, this is big chance that this is rheumatic fever again. So this is raised ASR, erythrocyte sedimentation rate, and C-reactive protein. This is signs of inflammatory process. This is leukocytosis, prolonged PR interval on ECG. This is a sign of cardiac damage, cardiac muscle damage. No, and plus evidence of streptococcal infection, such as positive throat cultures for group A streptococcus, elevated streptolysine O, or other streptococcal antibodies, or history of recent scarlet fever. So let's talk about that. And actually, what about this Duquette joints criteria? For example, if patient presented with carditis and polyarthritis, this is two major criteria. We can say that this is rheumatic fever. Or we have one major criteria, for example, carditis or polyarthritis, and few minor criteria, for example, fever, raised ASR, leukocytosis. Also in this case, we can say that this is rheumatic fever. Clinical features. Let's talk about each major criteria. Carditis. How we detect carditis? Carditis manifested as new or changed heart murmurs. So appearance of heart murmurs, which usually tell about damage of valves. The appearance of new heart murmurs, because previously also patient may suffer from some heart disease. So changes or appearance of heart murmurs. Development of cardiac enlargement or cardiac failure. The cardiac enlargement or cardiac failure, you know signs of cardiac failure, the dyspnea, appearance of weakness, dyspnea, dependent edema, or cardiac enlargement you can detect by percussion, by auscultation, or for example on X-ray examination. Appearance of pericardial infusion. This is sign of pericarditis. Raised ST segment, or signs of myocarditis. For example, inverted or flattened T waves, or first degree or greater AV block, or other cardiac arrhythmias. All this tells about some damage of the heart. So signs on ECG also tells about damage of heart, or what is damage. This is carditis. Transient diastolic mitral murmur due to mitral valvulitis, so-called Carey-Coombs murmur. I showed you vegetations on actually mitral valves or other valves, and these vegetations may cause transient, so appear, disappear, diastolic murmur, diastolic mitral murmur, Carey-Coombs murmur due to mitral valvulitis and appearance of these vegetations. This is heart. Non-cardiac features. Non-cardiac features. There is usually a fever with an apparently excessive tachycardia. So rheumatic fever means that it's usually presented with fever, with rise of temperature. Then arthritis. Arthritis associated with rheumatic fever classically is a fleeting migratory polyarthritis affecting large joints such as knees, elbows, ankles, wrists. So joints swollen, red, tender. Inflammation in one joint recedes, another become infected. Once the acute inflammation disappears, rheumatic process leaves joints normal. So again, what's essential for rheumatic arthritis? Because we have different types of arthritis. We have arthritis due to rheumatic fever, we have rheumatic arthritis, we have other types of arthritis. So what about rheumatic arthritis? First of all, big joints. We have damage of big joints. Again, this is ankles, knees, elbows, big joints. Second, usually symmetric. Symmetric, it means that two ankles affected, or two actually elbows affected. Then we talk about that inflammation, we can say fly from one group of joints to another, meaning what? For example, first we have inflammation of ankles. After some time, ankles becomes normal, but we have inflammation of elbows. So inflammation jump, fly from one group of joints to another group of joints. And finally, after attack of rheumatic fever, joints stay normal. The rheumatic process leave the joints normal. No problems with function, with form of these joints. Again, joints recover completely. Joints recover completely in case of rheumatic arthritis. What else? Next, we have affection of central nerve system. Affection of central nerve system presented due to as so-called Sydenham's chorea. Sydenham's chorea. No, Sydenham, name of the doctor. So Sydenham's chorea is involvement of the central nerve system that develops late after streptococcal infection. Now, sufferers noticeably, we use term fidgety, and display spasmodic unintentional choreiform movements. The speech is often affected. We talk about children's because usually rheumatic fever affects children's, and children's behavior changed as they have a bad behavior. They can present with some unintentional movements, especially of face. Their speech is affected, but actually this is damage of central nerve system. Now, fortunately, usually all these disappear without consequences. All this also disappear. As for joints, no actually bad outcomes of this Sydenham's chorea. Skin. Skin manifestations include erythema marginatum. This is specific transient pink rash with slightly raised edges, occurs in 20% of cases. The erythematous areas found mostly on the trunk and limbs, callus into crescent or ring-shaped patches. No, let me show. It's better to see. You see round shape rashes. You see round shape rashes. Sometimes we talk about wheels, like wheels, some rounds. Erythema marginatum. Marginatum, it means that edges of these wheels, more red the central part. That's why we talk about erythema marginatum. In other presentation, the erythema marginatum, like again wheels on the skin. What else we can find on the skin? Subcutaneous nodulus. This is painless, pear-sized hard nodulus beneath the skin. may also occur particularly over tendons, joints, bony prominence. Now again, this is some nodulus under skin, beneath skin. Oh, such this one, near spine, we have some nodulus under skin, subcutaneous nodulus over spinous processes on the back of patient with acute rheumatic carditis. How we can confirm? How we can confirm rheumatic fever? How we can confirm rheumatic fever? What additional investigations should be done? No, first of all, we are searching for streptococcus. And again, remember, we can't find streptococcus in the heart or in joints. Usually we can find this streptococcus somewhere in throat. That's why we use throat swabs cultured for a group A streptococcus. Serological changes. So we search for changes in blood. Serological changes meaning what? We're searching for antibodies against streptococcal infection, which tells that yes, immune system of this patient meet this germ, and antistreptolizine O titer and other antistreptolizine titers performed and may tell us that in the past this patient met streptococcal infection. Non-specific indication of inflammation. Non-specific indicators of inflammation such as ESR, C-reactive protein, usually also elevated. This is inflammation. This is inflammation. Prognosis. More than 50% of those suffer acute rheumatic fever with carditis will later, after 10-20 years, develop chronic rheumatic valvular disease, predominantly affecting the mitral and aortic valve, and this is the most dangerous outcome. Again, this is damage of the heart and mostly damage of heart valves. You see, half of people with rheumatic fever in future presented with heart valve disease. Mostly, you see, we have affection of mitral valve, about 50%, mitral and aortic valves together 40%, and other valves affected rarely. I told you that mostly, in most of cases, we have affection of mitral and aortic valves. Mitral and aortic valves. How to treat rheumatic fever, how to prevent, this is topic for your future studies. Now we are talking only about investigation and diagnosing of this disease. Next, what we'll talk about, this is outcomes of rheumatic fever, and first of all, this is mitral stenosis. This is mitral stenosis. Of course, you remember that mitral valve placed between left atrium and left ventricle. The left atrium and left ventricle. What does it mean, mitral stenosis? It means that mitral valve can't open completely. When mitral valve should be open? Mitral valve should be open during diastole, when we have filling of left ventricle, when blood from left atrium go through this valve and fill left ventricle. And the problem happened that this blood can't pass through this narrowed stenotic mitral valve. So, almost all mitral stenosis due to rheumatic heart disease. At least 50% of sufferers have a history of rheumatic fever, chorea. What we are talking about. The single most common valve lesion due to rheumatic fever is pure mitral stenosis, 50%. Mitral valve affected in over 90% of cases of those with rheumatic valvular heart disease. More common in women. No pathological process results after some years in valve thickening, cusp fusion, calcium deposition, and narrow stenotic valve orifice, and progressive immobility of the valve cusps. So the main idea, inflammation of mitral valve, inflammation of endocardium, because actually valves, this is endocardium, results in the damage, which finally results in mitral stenosis. Valve, this is door. The door can't open completely. The same happened with valves. This opening, this valve, this door can't open completely. Normal valve orifice, 5 square centimeters, reduce approximately to 1 square centimeter. Just imagine, instead of 5, only 1 centimeter. In 5 times decreased in this size. And in this case, severe mitral stenosis is present. In order that sufficient cardiac output will be maintained, the left atrial pressure increase and left atrial hypertrophy and dilatation occur. Consequently, pulmonary venous, pulmonary arterial and right heart pressure also increase. So again, imagine the picture I told you. So what happened? If blood can't pass through left atrium to left ventricle, what happened? Blood stay in left atrium, pressure in left atrium increase, left atrium increase in size, enlarged, hypertrophic becomes. Then what happened? Right ventricle pump blood into small circle, into lungs. But this blood then collected in left atrium and can't pass through this narrowed mitral valve. The result, we have rise of pressure first in left atrium, then we have rise of pressure in small circle in lungs, and we have rise of pressure in right ventricle. So right ventricle should pump blood with high force. The result, we have hypertrophy of right ventricle too. So remember that in mitral stenosis, we have hypertrophy of left atrium and right ventricle. Left atrium and right ventricle enlarged, hypertrophic, becomes hypertrophic in this heart valve disease. So increase in pulmonary capillary pressure is followed by the development of pulmonary edema. No, this is, I think, clear. So if pressure in vessels of lung increase, pressure becomes so high that plasma leave vessels and fill what? Alveoli. When plasma fill alveoli, we call this pulmonary edema. Pulmonary edema. No, this partially prevented by alveolar capillary thickening and pulmonary arterial vasoconstriction. No, pulmonary hypertension leads to right ventricular hypertrophy, dilatation and failure. So idea is following. Okay, when pressure rise in arteries of lungs, what happened? Just trying to resist, these arteries constrict. As a result, again, we have a rise of pressure in lungs, rise of pressure in arteries of lungs. Rise of pressure in artery of lungs means what? That we have rise of resistance. That for right ventricle, it's very difficult to pump blood through lungs, where is high resistance. Result, we have overload of right ventricle, we have right ventricular hypertrophy, then dilatation, then failure. Dilatation and failure. And right ventricular dilatation results in tricuspid regurgitation. So the most suffering part of the heart in case of mitral stenosis, this is left atrium and right ventricle. Left atrium and right ventricle. Symptoms. Usually there are no symptoms until the valve orifice is moderately stenosis. Now, for example, again remember I told you 5 square centimeters normally, and some signs appear only when it becomes only 2 square centimeters. When reduction in more than 2 times, 2-3 times. Now in Europe this doesn't usually occur until several decades after the first attack of rheumatic fever. Meaning what? That if patient suffered from rheumatic fever in his childhood, usually signs presented when he is in his 40s, 50s. So 40 years usually pass from the beginning of rheumatic fever till the presence of signs of mitral stenosis. children 10-20 years of age in Middle Far East may have severe calcific mitral stenosis. So in some countries this disease develop more rapidly. Okay, because of pulmonary venous hypertension, recurrent bronchitis, progressively severe dyspnea develops. So, result of pulmonary hypertension, how it's presented, may be severe dyspnea and bronchitis. Cough productive of blood-tinged frothy sputum is quite common, and occasionally frank hemoptysis may occur. So what we are talking about? If we have rise of pressure in vessels of lungs, finally, not only plasma, but even erythrocytes can go to alveoli, fill alveoli, and patient coughing up this bloody tinged frothy sputum. No, sometimes even hemoptysis. For example, rupture of some vessel may lead to hemoptysis, filling of alveoli with blood, and patient coughing up this blood. The development of pulmonary hypertension eventually leads to right heart failure and its symptoms of weakness, fatigue, abdominal or lower limb swelling. So again, remember, heart failure. If right ventricle fail, he can't pump blood into lungs because pressure in lungs so high. Failure of right ventricle means what? That this right ventricle can't accept blood, can't collect blood from big circle already. If blood can't be collected from big circle, blood stay in big circle and produce signs of congestion in big circle. Congestion in big circle presented as swelling of lower limbs, known as dependent or pitting edema, dependent edema, accumulation of fluid in abdominal cavity, ascites, enlargement of liver. So this is all signs of right ventricular failure. No, plus of course weakness, fatigue, and other general signs of heart failure. What else? Remember I told you that as blood can't go from left atrium to left ventricle, blood stay in left atrium, and left atrium enlarged. Left atrium enlarged many times. No, not many times, but enlarged in size. This may result in atrial fibrillation. Giving rise to symptoms such as palpitations, the atrial fibrillation. Remember, atrial fibrillation, this is when instead of sinus node, electrical impulses produced in many sides of atriums. As a result, we have fibrillation. Each part of atrium constricted with its own rhythm, and we see irregularity of heart rhythm. We tell that rhythm is not sinus. Atrial fibrillation. Atrial fibrillation, presented as palpitation sometimes, to tachycardia, may result in systemic emboly, most commonly to cerebral vessels, resulting in neurological sequelae. Mesenteric, renal, and peripheral emboly also seen. No, we told you that atrial fibrillation itself dangerous because it may lead to development of thrombi inside heart, and then these thrombi go out and reach other organs such brain, kidneys, intestine, producing infarctions, blockage, infarction, and death of tissues. Clinical pulmonary embolism as a result of mitral stenosis associated with atrial fibrillation, less commonly seen, but it's likely that subclinical pulmonary emboli occurs. So again, big left atrium leads to development of atrial fibrillation, and atrial fibrillation itself, this is serious disease which may lead to, for example, thromboembolia. to thromboembolia. On investigation of patients, sometimes we may see some signs. For example, face severe mitral stenosis with pulmonary hypertension associated with so-called mitral phases or malar flash. This is bilateral cyanotic or dusky pink discoloration of the upper cheeks that is due to arteriovenous anastomosis and vascular stasis. So we have some redness of cheeks, the redness of face, and this is known as malar flash, the malar flash, or specific mitral phase we also refer. Pulse. Mitral stenosis may be associated with small volume pulse, which is usually regular early on the disease, and if disease progress, when patients most are in sinus rhythm. However, as the severity of the disease progress, many patients develop atrial fibrillation, resulting in irregularity of pulse, and development of atrial fibrillation in this patient often causes a dramatic clinical deterioration. So why pulse is small volume pulse? Now, how we check small volume pulse? You find peripheral pulse, and find that this pulse is weak, small volume. Because if blood again can't pass through mitral valve from left atrium to left ventricle, as the result, left ventricle eject less blood than normal. If left ventricle eject less blood than normal, it leads to small pulse, because pulse depends on how much blood ejected to vessels. Again, at the beginning, pulse is regular, but when atrial fibrillation develops, pulse becomes irregular. Jugular veins. If right heart failure develops, obvious distension of the jugular veins. So you can find distant jugular veins down the patient's neck. No, this is clear why, because again, this is congestion of blood in big circle and everywhere, in vessels of liver, in vessels of intestine, and superficial vessels like jugular veins. They are just visible, and you can see this distant jugular veins, distension of jugular veins. Palpation. What you can find on palpation of the heart? Tapping impulse felt parasternally on the left side, which is not localized. This is result of a palpable first heart sound combined with left ventricular backward displacement produced by an enlarging right ventricle. Sustained parasternal impulse due to right ventricle hypertrophy may also be felt. So what we're talking about? Remember that anterior surface of the heart, if you see on the patient, this is right ventricle, because left ventricle placed somewhere on the left and back. And that's why, as in mitral stenosis, we have enlargement of right ventricle. This right ventricle produces heart pulsation, and this pulsation may be even palpable. You put your palm or your fingers on the left edge of sternum, and sometimes we can find such pulsation due to pulsation of big right ventricle. Auscultation. Remember, I told you how to answer questions about auscultation if you understand what happened. Let's do it again. We talk about mitral stenosis. What does it mean? So, okay, let's talk first about sounds. We have loud first heart sound. Why first heart sound becomes loud? Again, first of all, where this first heart sound becomes actually loud under mitral area. So first point of auscultation, you can find loud first heart sound. It's possible to explain. Remember, in case of mitral stenosis, less blood enter left ventricle. And when left ventricle contract, in left ventricle we have less blood than normal. That's why for left ventricle it's very easy to contract, and contraction becomes very rapid. And if contraction is rapid, pressure in left ventricle rise rapidly. As a result, this force which close mitral valve, because don't forget that first heart sound, this is closure of mitral and tricuspid valve. The closure of mitral and tricuspid valve. What closed this valve? This valve closed due to regurgitation of blood when left ventricle contract. And if less blood, this regurgitation faster than normal, than usual. As a result, first heart sound becomes more audible, becomes more loud, because this door mitral valve closed with high speed and beat and create loud heart sound. But if this mitral valve becomes calcific, becomes damaged, sometimes we can't find this sign, and this sound, first heart sound, becomes not loud but sometimes even quiet. It depends. What else? As valve suddenly opens with the force of the increased left atrial pressure, opening snap will be heard. Opening snap, this is additional sound, Remember I told you that usually we can hear only closure of valves. As usually we can hear we can hear closure of valves, opening of valves, usually not audible. Okay, you can open door and close door, and you will hear that opening of the door usually inaudible, closure of the door produce some sounds. The same for valves. But as in case of mitral stenosis, we have very high pressure in left atrium, and this door is opening with very high force, high speed. As a result, we can hear this opening, and we call this opening opening snap. Opening snap. So, first of all, in case of auscultation of patient with mitral stenosis, if we talk about sounds, what we can find? Loud first heart sound, opening snap, then second heart sound. Okay, what about murmurs? What about murmurs? I told you how to answer question about murmurs, and let's discuss together. Okay, we have mitral stenosis. What does it mean, mitral stenosis? It means that mitral valve can't open completely. When mitral valve should be opened? During diastole, when blood from atriums fill ventricles. It means that that mitral valve can't be opened completely during diastole. It means that we have some small opening, and small openings in all cases produce murmurs, I told you. That's why which kind of murmur you can find in case of mitral stenosis? Diastolic murmur, because again, mitral valve should be opened completely in diastole. It can't be opened due to stenosis. As a result, we can find diastolic murmur. Now, you can see that it's written that you can find low pitch, rumbling, mid-diastolic murmur, best heard on the with the bell of stethoscope, held lightly at the apex with the patient lying on the left side. So this is so-called condition when we can find murmurs somewhere out of the heart region. Remember that usually murmurs heard only under the heart. But in this case, when patient especially lie on his left side, because on the left ventricle becomes close to the chest and all sounds transmitted better. And in right in the left axillary area, you can find such murmur sometimes. Okay, if the patient in its sinus rhythm, the murmur becomes louder at the end of diastole as a result of atrial contraction, so-called presystolic accentuation. So now on this picture you can see what happened in case of mitral stenosis. This is first heart sound. Okay, this is heart sound, then opening snap, and then diastolic murmur. Okay, first heart sound, which may becomes louder, then second heart sound, then opening snap, and actually then diastolic murmur. Then you can hear diastolic murmur. What else? Chest X-ray. Chest X-ray usually shows a general small heart with an enlarged left atrium. Why small? Because on X-ray difficult to detect enlargement of right ventricle, because right ventricle placed in the middle of the heart, and enlargement is not detectable by X-ray with X-ray. That's why X-ray shows us enlargement of left atrium. Now again, don't forget that X-ray is not number one actually method to detect enlargement of the heart now. ECG, more actually important. The sinus rhythm in sinus rhythm ECG shows so-called Bifid P wave. Owing to delayed left atrial activation. This P wave known as P mitrale. Okay, let me show. This is P mitrale. Its P wave becomes wider. Why it becomes wider? Because again, left atrium enlarged, and for electrical impulses needs more time. Needs more time to cover all atriums. As a result, P waves enlarged in size, and you can see two pikes, like camel, with two pikes. And this is known as P mitrale. This is normal P wave. This is normal P wave, and this is P mitrale due to big enlarged left atrium. Now, as the disease progresses, ECG features of the right ventricular hypertrophy. Then instead of P mitrale, you may find atrial fibrillation, because it's frequently present. What else? Signs of right ventricular hypertrophy, also seen on ECG. This is right axis deviation. Tall R waves in lead V1 may develop. Again, this is what you can see. Vertical or right position of electrical axis. When R3 more than R2 more than R1, remember that normally R2 should be tallest. In case of right position, tallest R becomes in third standard lead. And in chest leads, we see what? Tall R's in V1, V2, and deep S in V5, V6. This is again signs of right ventricular hypertrophy. Of course, the most important investigation, this is echocardiography. Echocardiography alone sufficient to judge the severity of mitral stenosis, such as decision regarding surgery can be made. Again, echocardiogram, this is best way how to detect what has happened. You can see valves, you can see amount of blood passing through this mitral valve, you can see enlargement of ventricles, of atriums. So this is the best way how to detect this heart valve disease, and finally to make a decision of to do surgery or avoid surgery. Complications of mitral stenosis. Again, atrial fibrillation, I told you, systemic embolization, pulmonary hypertension, pulmonary infarction, chest infection, infective endocarditis rare, tricuspid regurgitation, right ventricular failure. So this is rather serious condition, Again, in severe mitral stenosis, without treatment, patient even may die due to heart failure, development of severe heart failure. Okay, final topic. This is mitral regurgitation. Mitral regurgitation. Again, rheumatic heart disease 50%, prolapsed mitral valve also common cause of mitral regurgitation. Understand what happened. What does it mean, mitral regurgitation or mitral insufficiency? It means that mitral valve can't close completely. When mitral valve, which phase of the heart mitral valve should close completely? During systole, because during systole mitral valve closed and blood ejected from the left ventricle to aorta, and mitral valve prevents regurgitation from left ventricle to left atrium. If we have regurgitation, some portion of blood return to left atrium. As a result, left atrium overfilled with blood, and during diastole, all this big amount of blood again fill ventricles, and happen that some portion of blood, without any reason, just goes up and down, from atriums to ventricle, from ventricle to atriums. We have overload of the heart with volume, because in this case, left ventricle should pump more blood than normal. Should pump more blood than normal. Just imagine that. For example, left ventricle eject, 200 milliliters of blood each time. But normally all these 200 milliliters go into aorta. But in our case, 100 milliliters instead of going to aorta return to left atrium. And it means that this part return to left ventricle during diastole, and again this 100 milliliters without any reason goes up and down. This causes overload of left ventricle, and the result hypertrophy and development of left ventricular failure in the future. Which part of the heart affected? Left ventricle again and left atrium, the enlargement of left atrium and left ventricle. Okay, regurgitation into the left atrium produce left atrial dilatation, little increase in left atrial pressure if the regurgitation is lot standing. Other regurgitation follow is accommodated by large left atrium. With acute mitral regurgitation, the normal compliance of left atrium doesn't allow much dilatation, and the left atrial pressure rise. So what is acute mitral regurgitation? Let me say, if it's a rheumatic fever, this process develops slowly. Acute mitral regurgitation happens, for example, again, remember anatomy. Our mitral valves, they have special muscles, papillary muscles, and special threads which don't let cusps of mitral valve open into left atrium. In some cases, we have a rupture of these connections, rupture of these muscles, and the result, for example, due to myocardial infarction. As the result, mitral cusps of mitral valve easily open into left atrium, and suddenly some portion of blood return to left atrium. If it's happened rapidly, no time for accommodation, because it's happened day by day. A patient has a time, or patient's heart has a time to enlarge his atrium, and atrium can accommodate this big amount of blood. If it happens rapidly, no time for this. Thus, in acute mitral regurgitation, left atrial V wave greatly increased and pulmonary venous pressure rise to produce pulmonary edema. Since a proportion of the stroke volume is regurgitated, stroke volume increases to maintain the forward cardiac output, and left ventricle therefore enlarges. So again, what I mean, remember I told you, imagine that 200 milliliters of blood ejected normally. In case of regurgitation, 100 milliliters goes back to atrium and then return to ventricles. In this case, actually, left ventricle should eject 300 milliliters of blood, because 200 milliliters go into aorta and 100 milliliters just go back to atriums. As the result, again, we have overload of left ventricle with volume, and to increase sufficient cardiac output, we have enlargement of left ventricle. Mitral regurgitation can be present for many years, and cardiac dimension greatly increased before any symptoms occur. So enlargement of the heart due to enlargement of left ventricle and left atrium. Increased stroke volume is sensed as a palpitation. Sometimes patient can feel these heart beats because big left ventricle beat with high force, contract with high force, and patient can feel such palpitations in his chest. Dyspnea. Finally, heart fail, left ventricle fail, we have development of pulmonary hypertension. No, as a result, we have, as usual, dyspnea. The patient feels dyspnea, weakness as a result of this heart failure. What else? Fatigue, lethargy. Remember, in all kinds of heart failure, the same symptoms: fatigue, weakness, loss of lung capacity due to reduce of cardiac output. We talk about congestive heart failure, cardiac asphyxia may develop in some cases. Thromboembolism is less common than in mitral stenosis. Signs, what we can find on examination of the patient. Examination of the heart. Again, we have enlargement of left ventricle and left atrium. As a result, we have laterally displaced thrusting diffuse apex beat, systolic thrill. Diffuse apex beat means what? That apex beat shift to the left due to big left ventricle, and as left ventricle becomes very big and strong, when you touch, when you feel this big apex beat, because heart with big force beat the chest and you can feel these beats. Systolic thrill. Thrill, I told you that this is specific vibrations of the chest. This is actually just low pitch sounds of murmur. The low pitch sounds of murmur, low frequency sounds of murmurs, they may be felt with your fingers as vibrations. What happened with sounds and murmurs? Sounds. First sound becomes weak, soft. Why? Because again, if we are talking about incompetence that heart valve can't close completely. If it can't close completely, these cusps can't beat the heart with high force. And the result, just imagine, you have broken door. The broken door can't close with loud sound because it's broken. The same happened in the heart, and that's why we have soft first heart sound. First heart sound becomes soft or weak. Murmur. Again, let's think together. Which kind of murmur we find in case of mitral regurgitation or mitral incompetence? Again, what does that mean, mitral incompetence? Mitral valve can't close completely. When mitral valve should be closed? During systole. If during systole it can't be closed, some part of blood regurgitate from ventricle to atrium. When this blood squeezes through small opening, it produces murmur. That's why in case of mitral incompetence or mitral regurgitation, we have systolic murmur. Pansystolic. It occupies the whole systole. This murmur loudest at the apex. Sometimes it's may be heard even in axilla, because it's rather loud, severe sound, and these vibrations may be transmitted to axillary region. What else? Prominent third heart sound owing to sudden rush of blood back into the dilated left ventricle in early diastole may be heard. Remember about gallop rhythm, this is additional third heart sound. This is due to third heart sound. What is it? This is vibrations of the left ventricular wall when blood goes from atrium to ventricle, beats the wall and creates some vibrations, we hear sounds. In case of mitral regurgitation, huge amount of blood fill left ventricle, beat with high force. As the result, we can find additional third heart sound, and sometimes we talk about gallop rhythm, when actually instead of 2 sounds we have 3 sounds, and it's similar as you can hear gallop horse, the galloping horse. If atrial fibrillation happened, we can find arrhythmia. X-ray, we find left atrial, left ventricle enlargement of left ventricle. ECG, again, ECG show us signs of enlargement. As a result, if we have enlargement of left atrium, left ventricle, we find signs of enlargement of left atrium and left ventricle. So, left atrium, what we can find? This is so-called, again, as I told you, P mitrale, the bifid P waves wide and P waves with 2 pikes. And if we talk about hypertrophy of left ventricle, this is picture, we can see what? Tall R's in V1, V2 and deep S in V1, V2, deep S in V1, V2, and tall R in V5, V6. Deep S in V1, V2, and tall R's in V5, V6. And summarize, if you measure S in V1 and R in V6, and summarize the S in V1 plus R in V6 more than 35 millimeters. This is also sign of left ventricular hypertrophy. ECG also shows dilated left atrium and left ventricle, or echocardiogram. Of course, again, echocardiogram, this is most advanced test investigation to detect all such changes. Again, echocardiogram shows dilated left atrium and left ventricle. Maybe specific features of cordial papillary muscles rupture. Doppler can determine velocity of the regurgitant jet, so you can see even regurgitation of blood from ventricles back to atriums. Okay, that's all for today. Don't forget at the end of the lecture, again, write your name and group number on the wall in Vkontakte, not in the chat again of the video, but on the wall of Vkontakte, on the wall Vkontakte.